Assalamualaikum warahmatullahi wabarakatuh. Good morning, everybody. Thank you very much for the opportunity. Today, I'm Makhyan Jibril, cardiologist, will be the host of the Asmiha Corner 2024. And we're very happy today to have Professor Vijay from the UK coming today. How are you, Professor, today?
I'm doing fine,
I'm
thank you.
fine. Yeah, you took a long journey to come to Indonesia.
Yes, my pleasure to be here.
Okay, very happy to meet you, and we are very inspired with your talk today. So we'll discuss about what you present in this cardiovascular research forum, which is SENIOR-RITA trials, right? Yeah. So can you explain a little bit more about these trials?
Sure. Well, it's my pleasure to be here with you all. So obviously, acute coronary syndrome, ischemic heart disease, is world's #1 killer.
Yes.
And we've had incredible progress in terms of pharmacotherapy and interventional strategy.
Sure.
So that makes you wonder why despite the advancements in care,
Yes.
why is ischemic heart disease #1 killer?
Yes.
And that's because we're living in an era where people are living longer. They survive cancer, they survive stroke, they survive respiratory condition, and ultimately cardiovascular disease catches up with them. And the underrepresented population are older people. Women are underrepresented in clinical research. So the people that we actually studied in our SENIOR-RITA trial are older people. So clinical practice guidelines. So I'm a task force member on the European Society of Cardiology clinical practice guidelines on acute coronary syndrome and the chronic coronary syndrome. The evidence base for the management of older patients is very minimal. And that's exactly in my own practice in the cath lab when I was treating patients with acute coronary syndrome. I felt there was a change in the demographics. From young people is the one that I learned intervention on. But we have more older people. What is the evidence? And there is very little evidence. And that's what essentially triggered the research into looking at the best strategy for older patients with non-ST elevation MI. 50% of end-STEMI happens in older people, but there isn't very much evidence. And also, older people get less and less pharmacotherapy, less and less invasive strategy. And then you wonder why. That's because not many research are done in the older people. And so we want to address all of that. And that's why we designed the SENIOR-RITA trial to look at patients who are 75 years of age and over, presenting with non-STEMI across the UK. So it was a UK-only study. And we randomized them into medical conservative care with secondary preventative medical therapy versus medical therapy plus invasive care, which involves coronary angiography with the view to revascularization either via PCI or bypass surgery.
I think this is very interesting topic because for us cardiologists, usually when we meet the elderly patient, we always having a confusion or maybe having a very hard decision making, whether we are doing the invasive strategy or conservative strategy. So I think your study will help us so many cardiologists in all over the world. So how you make sure that you can get that big samples, because I think your study is one of the biggest study for the elderly and STEMI, whether they are invasive or conservative, right?
Absolute hard work. When I designed the study, I was 10 years younger.
Oh, really?
It was 10 years ago, so full of enthusiasm.
I see.
But didn't really realize what the challenges were lying ahead. And of course, already recruiting the underrepresented population is hard work.
Yeah, exactly.
But then, of course, we were hit with the pandemic. Pandemic was the most, because in the UK, all research were brought to a halt. But I think for me, it's the patients that kept going. So when I go out onto the wards to see patients that were going to the cath lab, or when I approach them for the study, and they are so grateful. They're so grateful for that we are including them, because often older people are excluded from research. And so every time I face challenge, it's the face of the patients that kept me going, in all honesty, because there were many opportunities that I wanted to give up. This is just too much. And so it's the needs, the clinical needs, which I had in my focus. There is, if we give up now, we will end up with no evidence again.
Sure, yeah.
So we can't really give up. Giving up is not an option. So it's essentially perseverance and keep going and breaking through all of the barriers. So many barriers. And the barriers were very varied across the nations. In some centers, people were willing to, yes, fine, we'll put these patients into the study. And some centers, oh, they're old anyway, I don't want to put them. But I think the final, what got us there for me is essentially the inspiration coming from the patients and perseverance and hard working constantly. I was thinking about it for 24/7 pretty much.
24/7 for 10 years.
For 10 years.
Oh, that's super.
So that's what got us here. Yes.
And I think that makes the study special, right? Because it's a lot of effort, a lot of network as well, and a lot of perseverance. So that's why this study can be one of the biggest study up to date now.
Yes.
And then I think it's very challenging, right, to maintain your team until 10 years. So what's your strategy to make sure that all of the team can finish all of the data collation and finish all of the study on time?
It's a great question. But I won't go into great detail about the team because there has been changes in principal investigators. So PI, they move institutions, have to find a new PI to take over and provide training. Even within the study team, because it's happening over a 10-year period. They get another job and go somewhere else. And still, so it was constant training. It's constant training of the new individuals and having them engage and say, this is going to be, we're doing it for our patients. And yeah, again, even with the team, I presented when I presented at EAC, there are 75 committee members.
Oh, that's quite a lot.
That's trial management group, trial steering committee group, data monitoring committee, clinical events committee. 56 principal investigators, 700 site staff.
Whoa.
All of them need to know exactly what's happening in the trial in order for them to deliver the trial. So I was essentially responsible for providing training for each one of them. So I would write emails one-to-one. So I'll compose the emails on my Sunday afternoon. I didn't have a Sunday afternoon for the past several years. I would sit in my computer. Of course, you can't send emails out of hours. So I'll time it so that it goes out of my inbox on Monday morning. And then visit all these hospitals in person. So I'll go on the train, visiting Blackpool, Surrey, and Sussex across the country, pretty much. And also having the chief investigator site team meetings. So every month I will have a site teams meeting. So they all come in and join on the Teams call. So find out what their challenges are, provide them with the training. So it's to have the quality of the study that we have, we had to do all of that.
Yes.
You can't just because there is staff turnaround, you can't have missing data. If you have 30% missing data, what's the point? Nobody's going to believe your study.
True.
So you have to go back. So work with our team. Why is the troponin missing? Why is the follow-up missing? Why is the frailty score missing? Go back to the site and ask them to complete that. So it's a constant chasing, and that's how you're able to deliver a practice changing, not only for the UK, but as you said, for worldwide patients. So we have to do clinical trials with utter diligence. It can't be wishy-washy. It can't be superficial. You can't have missing data. You can't have follow-ups missing. It has to be attention to detail. Yeah.
So moving on to the perfection of the research, right? And the interesting thing is, I think you got the support from the British Heart Foundation. So how you convince them to support your study? Because very hard to convince them for supporting very long study.
That's right. They didn't believe me in the first instance. One, I'm a woman. We've never had a woman researcher, clinical researcher. But how I convinced them is by doing the pilot study. So in the UK, we have NIHR. So NIHR provides provided me with small funding, 150,000. So I went and recruited every single patient who was 75 years of age, came through our doors, through our department, and recruited them into the study. So by demonstrating, yes, it is feasible to recruit older patients into the study. And not only we, in the ICON 1 study, we did a complete evaluation. We assessed their cognitive function, we assessed the frailty score. It's essentially a head-to-toe evaluation. So even, there are studies where we looked at the clot characteristics using virtual histology, intravascular ultrasound, using OCT, demonstrating that we can do these things in older people with very minimal complication.
Yes.
So that pilot data, helped convince, she is capable to convince them, she can do it. And of course, we need to bring in several investigators on board, so the committee on board. And very, very grateful. Even 10 years ago when I didn't have, now I've led on 25 clinical trials, 11 as a national investigator and part of the trial executive committee, etc. But back then I didn't have any. So, but the BHF also sort of, I'm grateful for their support. They said we need women researchers, we need to support you. And to me, because of the trust, I wanted to work even more harder to deliver the trial. So,
I think women roles in the research are also very important. Even some of the Nobel Prize, they are women as well. Yes. And can you explain more about the conclusion of your research so that people will get the insight of the result?
So what we've shown is the primary outcome was composite of cardiovascular mortality or non-fatal myocardial infarction over a median follow-up of 4.1 years. And then, of course, we looked at the components of the primary outcome, which is cardiovascular mortality, non-fatal MI, many secondary outcomes, including subsequent revascularization, stroke, bleeding. So what we showed in SENIOR-RITA is that there was no difference in the composite of cardiovascular mortality or non-fatal MI between the two groups, invasive and conservative group. But there was 25% relative reduction in the occurrence of non-fatal myocardial infarction, and there was also significant reduction in the occurrence of subsequent revascularization. So we're able to prevent these people from coming back to hospital with further heart attacks, as well as further procedures. So improving the quality of life. But these people are older anyway, so doing the interventional procedure is not able to save their life. So we need to draw the line somewhere. And but it certainly improves the quality of life rather than the quantity of life is the message. And we're able to, the clinicians know what they are doing is going to impact for their patients, as well as the patients can be given the decision, actually, you've had a heart attack, I'm happy to do the procedure. It's not going to prolong your life, but it's going to prevent you from getting readmitted with further heart attack and further repeat procedures. So that is the message. And we also showed that the invasive procedure is safe because the procedural complication rate, despite the older age, was less than 1%, including bleeding.
Yeah, I think that's very insightful for us because this is answering the hesitation of the cardiologists, and what that they need to answer to the patient if they're asking whether we are benefiting to this procedure or not.
That's correct.
Thank you. And last, maybe you have a special message for all young cardiologists who do the research for all of Indonesia.
So we need future. We need future researchers, future New England Journal publishers. Not publishers, authors leading on world practice changing, because cardiovascular disease is still the number one killer, and we're not finished yet. So we need to continue doing more research. The younger generation from those that work with me are extremely bright. So don't be distracted by all the distractions that are happening. Focus. Be passionate about what you want to do, and then go and achieve that, because the next generation or the world changes, and we need to, our fight is not against each other. Our fight is against cardiovascular disease. So we have to defeat cardiovascular disease and make sure that our patients receive all of the appropriate care, regardless of where they are, whether they are in the UK, whether they're in Indonesia. So I think the bottom line is work hard, be focused, and yeah, we need you. We need you.
Well, thank you very much, Professor Vijay. It's very inspiring talk and giving us more energy for doing more research to tackle cardiovascular disease. So thank you very much. This is all for the today's session. See you next year in Asmiha 34th. Bye bye.